So I shared I was talking to Dean during break, and he said, and we were talking about bias and conditional bias and drinking the Kool-Aid, if you will, or whatever. And he said, look at this. And he's taking some coursework, and statistics indicate that the highest degree of bullying, workplace bullying, is in hospital-based healthcare systems and EMS. It's the highest incident statistically of workplace bullying. Pretty much, if you don't drink the Kool-Aid, you don't do it how we always done it, you're trying to change, no, find a new job. You don't fit. You don't fit with us. That's terrible, isn't it? That's terrible that we can't share our experiences and our education and our gut feelings openly. As a matter of fact, our next chapter that we get into this week is a team-based approach to healthcare. Yeah, we'll see how well that works, but I still need to talk to you about it. Okay, so we talked about blood pressure the other day. If I want to measure someone's output, I want to measure how strong their ventricle contracts. I want to know how much preload or how much pressure there is resting on the vessels. I can do that by obtaining what we call a blood pressure reading. And we'll do vital signs. We may actually do some of those, if not this week, but next. We can measure the pressure that's on the vessels at rest, and then we can measure the pressure on the vessels when the heart contracts or goes into systole. Now, the difference between those two numbers, the systolic number is going to be bigger than the diastolic number. If I take those two numbers and I subtract them, diastolic from the systolic, I get some number called the pulse pressure. So what is pulse pressure? It's the difference between the systolic and the diastolic. So 120 over 80, a blood pressure reading 120 over 80, gives me a pulse pressure of, so if I subtract the diastolic from the systolic, 40, okay, very good. Now, it's measured in millimeters of mercury. You need to know that. Every EMT needs to know that. Millimeters of mercury, capital H, little g. If you want to learn something else, a millimeter of mercury is also a torr, T-O-R-R.
You say
Blood pressure is measured, the unit. When I say 120 over 80, I'm saying 120 millimeters of mercury over 80 millimeters of mercury. Hunter, that means that's enough pressure to make mercury rise 120 millimeters in a tube. The medical term for blood pressure cuff is a sphygmomanometer. I could probably work that spelling out, but why memorize what you can reference, right? Sphygmomanometer, blood pressure cuff. It gives me a great baseline, Jonah. If I tell Gus, blood pressure's low, it's kind of like telling Gus I'm rich. It's all relative to what? What do you mean blood pressure's low? If I tell you the blood pressure is 60 over 40, Gus goes, blood pressure's low. Okay, why is it low at 60 over 40? But initially, I can either anticipate it being low, I can look at someone and just tell you it's low. I'm looking at all of you right now and telling myself, if I was to assess all of you would at least be normoperfusion. How do I know that? Well, back to what you said earlier. Your mental status is here. You walked in. I don't see a mechanism of injury. I don't see an illness. You haven't reported an illness. So I'm to make the assumption, but I don't know until I go check everybody's blood pressure. And when I check everyone's blood pressure, I'm not going to find the same pressure. If I check everyone's breathing rate, I'm not going to find the same breathing rate. Here's a funny, you ER dwellers. You ever seen the board in the ER where they put the vital signs up? Room so-and-so's vitals are this, and their vitals are this, and their vitals are that. Unless there's a machine taking the respiratory rate, look how close the respiratory rate is, if it's not all the same. I've seen like 20 rooms in a hospital, 20 patients, a patient in each room. The respiratory rate's 14 all the way down the board.
Do you know why that is?
Yeah.
Our Cerner system, if you put anything above 20 or lower than 14, it'll flag it, and then
You have to do something about it.
Yeah. I remember one time I went to start at 23 because that was what it said on the screen, and the nurse said, "No, don't do that because then I have to do something." That's what she said. Really did that.
Oh, I know. We were trying to discharge my mother from sepsis earlier in the summer, and I'm there to take her home. And they went and got a set of vital signs, and her blood pressure was not over 100 systolic, like 98. And they're like, "Man, we've got to get your blood pressure up before you can go home. She's been here 5 days for you to do just that. Maybe she's not ready to go home." And they're like, "If we lower the head of your bed and raise the feet, maybe we can get it over 100 and you can go home." I didn't care because she needed to get the hell out of there. I already knew where I was taking her. We can do this AMA, or you can make up your number 100. We can stand them on their head and get them to that magic number that you can discharge. And you want to look at them and go, and I know it's Memorial Day and you're short-staffed. So that's why you want to get her home. If it wasn't Memorial Day, she'd have stayed. I guarantee you she would have stayed. Over the weekend, I told Mama, I said, "It's Memorial Day weekend. We'll see how this goes." "I haven't seen a doctor all weekend. I guess I'm doing well." No, they're not coming around. I thought you were going to say, a lot of people will not bother to measure respirations. They just look at them and go, "Yeah, looks like all of you are probably about 14." Because we won't take the time to measure them. We have this pulse ox now. They'll give us our pulse. Nobody actually takes a pulse. Feels of it, feels the quality of it, feels the regularity of it. They just stick something on your finger and go, "Now your pulse is 88. Nobody sat and counted for 30 seconds and got 44 and multiplied it by 2. Let me just put this blood pressure cuff on you and push start. No one actually put a blood pressure cuff on. Do you know how much data you're gathering when can I take your blood pressure? I got a mental status assessment going. If they say, "Yeah, sure, no problem." Or, "Hey, yeah, good idea. It usually runs low. It usually runs high. Yeah, check my blood pressure, young man. Skin tone, skin condition, temperature, is it sweaty, is it dry, is it flaky? Do I smell something when I get close to them?" Smell like nail polish remover. You're in ketosis. You a diabetic? "I don't think so. Grandpa was, but I don't think I am." Check your blood sugar. 700. Congratulations. I just deemed you a diabetic. That's probably why you feel bad. That's probably why your skin's so dry. I couldn't have done that unless I got up there in his face and smelled the breath. And what I'm smelling is ketones coming out of his breath, because the body's got to get rid of the acids, and ketones are an acid. And how do you get rid of the acids? You breathe them off, or you pee them out. 2 mechanisms: breathe them off or pee them out. Gas exchange. Then I'll say, "Been going to the bathroom a lot?" God, 5 and 6 times a night. And I can't get enough to drink. "Oh, you have polydipsia, polyuria, and polyphagia." and you've got 700 blood sugar with ketones. I know there are acids in your blood. I know your blood pH right now is going to be lower than 7.35. Let me put a capnographer on you. Oh, we don't put capnography on anybody unless they're in cardiac arrest. A little late. You know how much those cost? Do not put capnography on anybody unless they're in cardiac. No, it's a lab tool. Your capnography reading is 60. That's above 45, isn't it? Why is it 60? Because the body says, I got to get rid of this excess acid somehow, and acid disassociates as CO2 with the bicarb dissociation up there, right? So now you're in diabetic ketoacidosis. And you just thought you had the flu. How did I get there in that assessment? I got close. I touched. If I slap a blood pressure cuff on and let the machines do all the number measurement for me, and they do a great job of measuring numbers. I'm not going to sit up here and tell you they're inaccurate, because they should be calibrated, blah, blah, blah. But I'm missing so much by not getting down, talking, getting close. Now, some patients you don't want to get close to, but I like a long stethoscope, you know. I don't like those short ones where I get right up under the arm. But you get my point, right? I could probably find shock or something like that long before. Jonah is so mad. He's just sitting there in disgust right now because he's reflecting on some experiences he's had, and now he realizes, or you're realizing the why when you've had questions about why. It's going to get worse. That's why I patted you on the back. Let's be empathetic with that, okay, guys, as we go through this. Sometimes it's better not to know anything. But at least you're aware now, and you can start chopping at some of those biases that you just get ingrained with. Okay, pulse pressure, difference in systolic and diastolic. We just talked about that. A pulse pressure less than 25 millimeters of mercury may be seen in patients in shock. So I take one set of blood pressure readings, and I get a number, and I get a pulse pressure. I go back and I take another set of blood pressure readings, like on a critical patient every 5 minutes, on a non-critical maybe 10 to 15. Make sense? But this guy's critical because he's got a significant MOI. So I'm going to measure this frequently. I'm looking for trends. Is he getting better or is he getting worse? Better or worse? Staying the same. Do you know when they say you're stable in the hospital? You may be down here, but you're just staying down there. You're not getting any worse, you're not getting any better, but you're bad. They said he was stable. Death is stable. Critical but stable. Oh, you didn't tell me it's critical. People hear what they want to hear too. People hear what they want to hear. If I see the pulse pressure getting narrow or getting closer together, or that 40 becomes a 30 and then it becomes a 28 and then it becomes a 20, what is that? What's that indicating? When that top number and bottom number get closer together, that means that pulse that's generated by that ventricle has less perfusion effect, right? Luke, to get the blood to the little toe, and I'll tell you why I keep bringing up the little toe here in a minute. To get the blood to the little toe, I have to have at least enough pulse pressure to push it all the way down there. It's going to take a lot of pressure right here to get it all the way down there, because remember, the vessel gets smaller and smaller. I got friction loss involved. There's some rules of hydraulics applying. Just do it, Brandon. Just do it. Here we go. PowerPoint over. Not really, but kind of. See, I was looking at Luke, and Luke was trying to comprehend, and Luke says, you're going to have to give me a little more than that. So this is all Luke's fault. Will you take the blame, Luke? Okay. There are probably others in here who feel the same way. So what am I drawing again? Capillary. Why is it a capillary? Got holes in it. What's leading to the capillary? This is an arteriole. It's the smallest of arteries. What's leading away from the capillary? Venule, the smallest of vessels. There are tubes, so what do they have in them? Smooth muscle. At the end of the capillary, I would call that post something. And at the beginning of the capillary, I would call that pre something. And tubes, we talked about the tube in your anus that closes down, that muscle that closes down, it's called a sphincter. There's one in your bladder, there's one at the end of your esophagus, there's another one at the end of your small intestine. There is also a sphincter at the beginning and the end of every capillary in your body. It's a lot of damn sphincters, isn't it? It's a lot of damn sphincters. And because they are muscles, they can open and close. Because they are muscles, they can open and close. So when the body needs to keep the perfusion status up at the tissue, ischemic sensitive tissues, heart, lungs, brains, liver, all that stuff we talked about, if it needs to keep perfusion there, alpha 1 says close off the periphery. Close off the periphery to bring blood to the core where the ischemic sensitive tissues are. So one way it does that is it starts clumping down on those sphincters. The sphincters start closing up. As those sphincters close up, do I get less perfusion here? And so I think, Jonah, you mentioned it, one of the early signs of shock is pale skin. Okay? Pale. You'll hear that term, pale. They're pale. Why? The sphincters have closed down. I don't have as much blood flow through it. So you also told me that these sphincters require energy to work. So there's a bad deal about shock. And shock in Murphy's Law, sleep in the same bed. Without intervention, things tend to go from bad to worse. That's the deal with shock. It's bad. Without intervention, it's going to get worse. These require energy. So what happens as you progress through shock, these sphincters start to weaken. And when they get weak, they tend to open up. When shock progresses, the sphincters will weaken and open up. And one of the things that will happen is your red blood cells will start stacking in here. You candy connoisseurs, you ever, you know the candy Rolos, the Rolo candy, it's in the tube. It's a little chocolate covered caramel things and you open them up. They're just stacked in there like Spree or whatever you want to say. I use Rolo for a reason. That formation of the red blood cells stacking up in there like Rolo candy is called the Rolo formation. Spelled a little different. Rolo formation. Since those are stacking up, how well do they absorb or get rid of or diffuse gases? Not very well. Respiration's failing, isn't it? Remember, things are going from bad to worse here. What I'm describing on the board is shock at the capillary level. So if you want a heading on your notes, it's shock at the capillary level. In the early stages, we just close the sphincters. As it gets worse, the pre-capillary sphincter will open and the red blood cells will stack up because this one hasn't quite given up yet. The body says, let's hold this one closed so we can increase the hydrostatic pressure and maybe get some, that's alpha 2 feeding back, see? That's alpha 2 going, hang on, let's try. But in doing so, the red blood cells stack up end to end. Stack them like candy. Stack them like poker chips. It's called the Rolo formation. Without intervention, things tend to go from bad to worse. So this one fails. The postcapillary sphincter gives up and opens up. Now, everything that has been in here is not, everything that was in here was stagnant, and now it is washed out. We call it the washout phase. The washout phase. So there for a moment, it just all got built up and was stagnant. And then when that last gate opened, everything washed out. Now, where is all this gunk going into circulation? So what's really happening, when we added the compensation, what was one of the earlier ways to compensate for shock? We turned up the breathing rate to get rid of extra CO2 and to bring in more O2. But really to get rid of the CO2, right? The next thing that happens is a sympathetic response. A sympathetic response. That was Wednesday's lecture. Alpha 1, alpha 2, beta 1, beta 2, dopaminergic. We got the dump of adrenaline. Adrenaline happened. Adrenaline goes in, and alpha 1 specifically closes off the sphincters to keep the pressure up, the perfusion up at the vital organs. Fasten your seatbelts. The next shock compensatory mechanism. Do not let him hit me, because I'm going to have my back to him and he's going to get mad when I put this on the board, okay? You better stay seated. The renin, angiotensin, angiotensin, aldosterone system. Renin, R-E-N-I-N, angiotensin, A-N-G-I-O-T-E-N-S-I-N, aldosterone, L-D-O-S-T-E-R-O-N-E.
What's the second word?
Angiotensin, A-N-G-I-O-T-E-N. I didn't have an eraser over there, I'm sorry. S-I-N. Aldosterone, L-D-O-S-T-E-R-O-N-E. System. Let me walk you through this. Don't worry about writing all this down. What I want you to know is what we get at the end of this little spill, okay? A person is going into shock. The first thing to come on board is the bicarbonate ions that are floating around the blood are going to tie up, if you will, with some of those CO2s, and we're going to transport that to the lungs, undo that equation, we'll blow off CO2. So we're going to see respiratory changes. So we have, we call those buffering systems. What are we buffering? We're buffering the acid that's building up due to anaerobic metabolism, due to a lack of perfusion, due to, okay? And then we're into categories, and we'll get into those later. So I got chemical buffering, respiratory buffering, renal buffering. So that same acid that's floating around to the lungs and undoing itself in the lungs is also the same acid that reaches the kidneys, and the kidneys get rid of that, and you pee out more ammonia, which is hydrogen based. nitrogen. It's truly nitrogen based, but you pee out these acids. Now the cool part about the kidney is whatever blood it takes in, when it sends it back out into circulation, it's fixed. It's fixed. It's cleaned up. But your kidneys only get, 5 to 10% of your circulating blood supply at any one moment. So it's not filtering all the blood at once, it's just filtering percentages of the blood. So the respiratory shows up immediately, but the kidneys are most effective, but they are a slow process. Are you with me on that? It may take days for the kidneys to straighten you back up. Now, you remember baroreceptors from a week ago? Baroreceptors measure pressure. They're in your body and they measure pressure. And I told you that baroreceptors are located in the aorta. It's a good place to take a measurement, isn't it? They're located in the carotid arteries. That's a good place to take a measurement because the carotid arteries are feeding the brain. The brain says, give me a set of sensors right here. Give me a sensor here in the heart or in the aorta. Give me a set of sensors, but no means is this an all-inclusive list. This is just the big boys. Give me a set of sensors at the kidneys. So you have renal means kidney, R-E-N-A-L, renal baroreceptors that are monitoring your perfusion pressures. I don't want to say they're monitoring blood pressure because they're not doing a systolic over diastolic. They're just monitoring pressures in relation to everything else going on in the body, and the autonomic nervous system makes a judgment on what to do. Now, one of the things that the kidneys do when they sense a decrease in pressure, and now we're at that big three-worded monster on the board, they release a hormone called renin. Like I said, don't worry about writing all this down because I'm paraphrasing it anyway. I'm making it short and sweet and to the point. The points where you need to understand. They secrete a hormone called renin. When renin is released in the blood, it finds angiotensin 1. Angiotensin 1 then says, renin has activated me. I will go to the lungs, and in the lungs, angiotensin 1 is converted into angiotensin 2. Through the use of an angiotensin converting enzyme, this is going to start looking familiar here for some of you. An angiotensin converting enzyme is going to convert angiotensin 1 into angiotensin 2. When angiotensin 2 leaves the lungs after this conversion process, it goes to the anterior pituitary gland in your brain and causes that to kick out another hormone called ADH, antidiuretic hormone. This antidiuretic hormone is going to go back to the kidneys and say, kidneys, hold salt. Hold salt. Because if I hold salt, in effect, I have held fluid or water. Since I need the fluids, because I'm going into shock, please hold on to some fluids. There's more to the story here. This ADH, which tells your kidneys don't pee, antidiuretic, don't pee, is also a potent alpha-1 stimulant. So what's that going to cause? When I stimulate alpha-1, what's that going to cause? Have to look back in your notes. That's fine. That's cool. Huh? Vasoconstriction. It's going to cause that capillary to clamp down. All of this is trying to maintain perfusion to the tissue, ischemic sensitive tissues. With me? It's going to clamp down on the periphery. It's going to raise the pressure by shrinking the size of the lumen. It's shrinking the diameter of the vessels. There's a law in physics that says if I put the same amount of volume through a conduit, a pipe, and I clamp down on the size of the pipe with the same amount of volume going through it, the pressure inside the pipe is going to go up. Matter of fact, you double the diameter, you quadruple the flow at the same pressure. We don't want to go off into hydraulics. How come blood pressure, patients who suffer from high blood pressure all the time are prescribed an ACE inhibitor, such as lisinopril? Remember I told you the other day, any drug that ends in pril is an ACE inhibitor. So what that drug does is it goes in and finds ACE, angiotensin converting enzyme, and says, you ain't working. You can't go to work today. So if you interrupt that multi-step process, what have you done to vasoconstriction? You've opened it up. Therefore, you got lower blood pressure. And if you suffer from high blood pressure, that may be the thing that keeps you from having high blood pressure. I want to say it's the thing you need, but I'd be lying. You don't have high blood pressure because you're lacking lisinopril. But in a shock patient who's taking lisinopril, what are they not able to do? They're not able to use that as a compensatory mechanism, are they? So they're already one step behind the power curve. And if you as an EMT or paramedic waited till the blood pressure fell before you recognized shock, and they're on an ACE inhibitor, now they're 2 steps behind the power curve. It's a double whammy. That's a lengthy process just to get there, isn't it?
So what's the point?
Huh?
What's the point to write down?
It's on, the switch has been flipped when the patient's going into shock. That's an excellent question. What's the point in understanding that? And I'm not asking you to recite that, but I need you to know it's there. So what's the point of me having you know it's there? Anybody? Watch this. Your textbook describes shock in a couple of ways. One way it describes shock is compensatory. The second one, decompensatory or decompensated. And then the third one it describes is irreversible. Okay? You'll find that in the text. If these are working, and the patient's numbers look homeostatic, and I'll just say numbers look good for simplicity, is everything fine? Well, wait a minute. Why are you saying no now? Why'd you change your mind?
Because you can't just look at the
It's not all about numbers.
Well, it's not about the numbers. It's also not necessarily just about how the patient appears either. I mean, it looks like you can be in shock, but look okay. So let's say numbers look good. I want to say patient looks good. Patient looks good. Oh, he looks good. But the reason I need you to understand this is all going on in the background is it may look good because he's compensating for everything. Here's even a scarier one. if you're looking at, say, blood pressure of 120/80, a person who would have that without insult or injury, when they go into compensatory shock, it may be 130/84. Because these mechanisms have done what?
Shut off.
Well, they're activated, so sometimes it just kind of overcompensates. It's like, you gonna bring this all on board? We'll probably even get a better number. Heart rate may go up a little bit. Why? Right here, dumped adrenaline, beta 1, I should say, beta 1. Blood pressure is looking pretty good. Urine output's down though. Well, I don't measure urine output in the field, do I? Antidiuretic though, and I'm losing fluids. Do you think the patient will get thirsty? So one of the signs and symptoms of shock is increased thirst. We don't give them anything by mouth, but they complain about getting thirsty. So I get a little bit of an increase in respiratory rate. Just a little bit. Now, if you're in the hospital, I guess, Jonah, you have to lie so you don't activate some other system and make somebody else busy, have to do a job.
To an extent, if the respirations are in like 28s, 30s, 40s, 50s, obviously then it is.
But we need to go back and ask ourselves, why is it up today? So get a little bit of increased heart rate, a little bit, and I might even get an increase in blood pressure in the compensatory phase. But a lot of times, it's like Jonah's getting at here, they're within normal limits though. I mean, my blood pressure my heart rate normally runs 70 at rest, and now it's at 98. But it's still not tachycardic. It's still 60 to 100. Your blood pressure's up a little bit. Well, you got a good blood pressure. I mean, anything better than 120/80's got to be good, right? That's what they tell us. Who said that was normal anyway? What was their research study? I don't know. The respiratory rates went from 12 to 18, but it's still within normal range. False identification there. Let's go to decompensatory phase. I'm going to use 2 arrows to indicate that the heart rate is really up now. That was the guy I talked about who got shocked so many times. He's up in the 140s, 150s. He's getting a whole lot of adrenaline dumped in his body. It's really working hard to compensate now. But the blood pressure is starting to fall. So if I wait to see the blood pressure down, where am I at? At least here.
So is the heart rate up? It's trying, I guess.
It's working so hard to try to compensate. The respiratory rate. Now we've activated something. Or sometimes you may see the respiratory rate start slowing down. That's due to fatigue of the muscles of breathing. I just can't keep that pace up. That's starting to fail. When you start transitioning from decompensatory to irreversible, some of these numbers start to take a nosedive, like a drastic nosedive. Like all of a sudden, now the heart rate possibly could be bradycardic in the 40s. And here's the typical example of what someone would say. He can't be in shock. His heart rate's just 40. You ever think it might be tired? You ever think it might have been pumping along at 160 here for the last 15 minutes? Well, he's not breathing very fast. You ever think he might be tired? When you start getting no heart rate, no breathing rate, no blood pressure, where are you real close to? Death. How do I know this is irreversible? If I was in the field, how would I know someone was irreversible? Well, one, if they're dead due to the mechanism of injury. But the second option is I may not. We may not know it's irreversible until we go back to the hospital 5 days later and find them in ICU being carried out by the funeral home. That was irreversible, wasn't it? We couldn't reverse it. Where do you intervene? as early as possible. As early as possible. Rude unhinging of life. Any questions about that? I have a pretty good overview there, isn't it? What happens when you go through shock?
What was the first step you would take?
I'm sorry?
If you came across a patient that was in shock, what was the first step you would take?
The first step I would take is allow myself and my team, my healthcare team, we got a potential shock patient. Because you're not really going to be able to do much for it, even at the paramedic level. Depends on what type of shock they're in too, and that's where we're going from here. So we have to identify we have to identify this chart. And this is where we're going to spend the rest of the morning. We have to identify this chart to answer your question, Hunter. So let's just play with this a moment. Let me go down, let me work this from the bottom up, okay? Because the bottom says low blood volume. When we think of shock, we're kind of trauma geared, trauma sexy, medical's boring, you know. We love calling the helicopter out for a major motor vehicle collision, but we don't really like calling it out for a little granny who's had a stroke, right? I mean, that's, little grannies are supposed to have strokes, and that's just another stroke patient, right? You like the trauma scenes. I get it, but medical is more of a thought process. So we're going to start from the bottom up. And the broad category is hypovolemic shock. We don't have enough blood volume to fill the container. Not enough blood volume to fill the container. And there are two subdivisions of that. There's hemorrhagic shock, and the word hemorrhage, Jordan, means to bleed. So hemorrhagic shock means you are low on volume because the gunshot wound to the thigh has allowed the blood to run down the sidewalk. It has left the body. Like Elvis has left the building, the blood has left the body. You've hemorrhaged to lose it. Non-hemorrhagic shock is my deer hunting guy who through nausea and vomiting and diarrhea has lost the fluids. Somebody who's in a real hot environment where they just sweat and sweat and sweat, losing lots of fluids.
So hemorrhage shock is blood loss?
Hemorrhage is blood loss. Non-hemorrhagic means fluid loss by some other mechanism. And there are a bunch of those. Fasting in a hot environment, yeah, you get the picture. Uncontrolled diarrhea for 5 days, just losing too much fluid.
I'm probably getting your head, but what type is it when they're bleeding inside?
It's still hemorrhagic. Good question, Billy. Remember, if the blood, and that's why I put that on the board the other day, if the blood is not in the vascular system, then it's extravascular, isn't it? And it does not count toward the volume, even if it was pooling up in my thigh. Blood that gets pulled up out in the free space. Do you know you can lose your entire blood content in your abdomen without your abdomen swelling? It just shrinks down the hollow the hollow organs in your body. I can put a liter in each lung. And then it wouldn't be a pneumothorax, it would be a hemothorax, meaning it's filled with blood. I can lose a couple of liters in each thigh. I can lose 2 to 5 liters in the pelvis. It's not on the ground, Billy, but it's not in the vascular system either. Doesn't matter. Doesn't matter. It's gone. It's over with. I can't get it back. Does that make sense to everybody? If you lacerate your liver and it bleeds out into your abdominal sac, it might as well be bleeding out onto the street. You know what makes that bad, Billy? You don't see it. I mean, if I walk up to somebody who's been shot in the leg and he's got arterial bleeding and every pulse it squirts blood out his leg, guess what I know? He's bleeding and I got to stop it. If he's got a liver lac that I can't see and it's over here seeping blood into the belly, I may not see that for 3 days when I get a big bruise down here in the bottom part of the belly. And I told Jonah a story at break, and I'll go ahead and tell you the story now, because it's relevant to everybody. When I don't see that bleeding, Billy, and the guy has compensated well enough to run, real quick, guy running from some bad dudes. Some bad dudes wanted to beat him up. They left a bar, you know. When there's dancing and drinking, and fighting. And so 2 or 3 guys in a truck started chasing a guy in a Jeep. They ran into Oklahoma, high rate of speed. The Jeep left the roadway, took out an aluminum highway lamp, light, clipped that off clean at the ground. That was lying over in the ditch, and then went down an embankment and hit a cedar tree, a large cedar tree, and went right up that cedar tree, and the Jeep came back down and fell over on its top. We're on scene, nobody around. Radius, keep looking in the woods, looking for a blood trail, you know, tracking the deer, right? Can't find the guy, or can't find anybody. I don't know who's in it or what's in it. Don't even know that he was being chased until later. This is all we know. This is back before cell phones were everywhere. We finally give up, which we hate to do, but we gotta go back we just can't find anybody. So after a significant amount of time searching, we drive back to the station. We see a guy running down the highway. Like, what's this guy doing? So we pull over. We don't even think this is our patient, right? This is just a guy out running on the highway. Strange things happen after midnight. Roll the window down. Hey, what's up? He's like, there you are. What? Well, I ran for help. Called 911. I wrecked my Jeep back there. And like, oh, was anybody with you? Nope, just me. I was running from some guys that were trying to beat me up. I hope they don't find me. They went on by when they saw me wrecked. Okay. Let's get you in the back of the ambulance checked out. And I knew where he had ran to get to a phone and where he was now. We're a mile and a half. He's moved a mile and a half. He does not show any signs of external hemorrhage. Get him in the ambulance. I get fooled. I don't play the game. His heart rate's up. Why? Well, he just ran a mile and a half, okay? His breathing rate's up. Why? Well, he just ran a mile and a half, and he's scared. That's about all I do for him. And I have the ability to be a paramedic if he was. So I take him to the hospital, TMC, trauma center. I don't notify the trauma center that I have a significant trauma patient. I don't think I have a significant trauma patient. And when I get in there, the doctor looks at him and says, what happened to this guy? And he tells the story and I fill in the gaps. And he looks at me and he says, you didn't call a trauma alert? I'm like, dude, he just ran a mile and a half. He's like, yeah, but you also told me you left the highway at a high rate of speed and struck a tree in a Jeep and could have been thrown from it. Yeah? What's your point, Doc? You know, what are you getting at here? He said, call a trauma alert right now. Let's get a scan of the belly. So he did the ultrasound scan of the belly, and he had free blood over his liver. When we say free blood, it means it had broken free from the vasculature, and he was bleeding in the belly. So he had to go to trauma surgery that night. He had, I'll go ahead and tell you now, your liver's sitting right here in the right upper quadrant, and there's a big ligament that lays in front of that liver. Kind of helps hold everything together there. Up on those deceleration injuries, that liver goes across that ligament, and that ligament acts as a kind of like a cheese slicer and can take your liver into 2 pieces and cause that tear. Ligamentum anteriosum, meaning in front of the liver. My bad. I messed up. At least I took him to the appropriate facility. Here's the other thing, though. You know what's really ironic about this? What I did for him is exactly what should have been done for him.
All you didn't do was just inactivate.
The only thing I didn't do was activate the trauma center. But I got him to one.
So would you not like feel with him? Like, you're like, hey, does this hurt?
I was so 3 o'clock in the morning pissed off, chasing somebody through the woods, got myself covered in ticks and ticks and whatever. Ticks and chiggers. And at 3 o'clock in the morning, and I'm not in a good way, man. I'm not in a good way. Fatigue has left me, and then you're intoxicated. You've been drinking. You've been out partying. You've been having a good time, and obviously you said something to piss somebody off, and now you're running from them. I mean, everything you've done today has added up to what's going on here. Now you want me to fix it? Now you want me to get up in the middle of the night and fix it? Yeah, I pay you to do that. I got to reflect on that, right? Yeah, I pay you to do that. And I'd appreciate you if you'd done it really well. Some people, if you back up 10 years ago, they would say, you should have started 2 large bore IVs on him and given him some fluids. That's not what we do. You should give him high flow oxygen. Nope, he wasn't hypoxic, so that's not what you should do. Even though I know paramedics today who would actually do that to this patient today. Everything I did for him was appropriate. But Billy, was he bleeding?
Yeah,
But it wasn't on the ground, was it?
Yeah.
So does it count? Yeah, it counts as blood loss. It counts as blood loss. That's a little different than a man who's been working outside in high triple-digit heat index and not drinking. Or maybe he's drinking Coors Light instead of water and electrolytes. Dehydrate you really fast. That would be a non-hemorrhagic shock. Does that make sense? Either way, volume's down. So we got to give them what they need or get them to a place that will give them what they need. My guy needed surgery and blood. The guy who's been drinking Coors Light instead of water and electrolytes needs water and electrolytes. So give them what they need or get them what they need. Let's back up to poor vessel function. This is an example of the container has failed. We call that distributive shock. Distributive just means the railroad tracks aren't intact. Something has interrupted that. We'll start at the bottom again. Psychogenic shock. We've already talked about that one. That's syncope. That's when you see something so horrific or such devastating bad news that you just cause your vessels to open up temporarily. You pass out. Syncopal episode. You hit the floor. Blood volume. The container shrinks back. Blood starts going to your head again. You're okay. How do you know if it's psychogenic shock? They recover from it really quick. I wouldn't even count that as shock if I were you. But we got to stick it somewhere. We got to stick it somewhere. I think I would just use that one more of as an awareness thing. It's like if you see something horrific and a family member runs up and goes, let me go in here. And you may be one of those who go, stop for a second. It's not good. Let me tell you the truth. Let me paint this for you. Let me prep you a little bit before you go in there because you have every right to see it, but let me just say it's not good. And then expect them to do what? Not listen, run in there and pass out. So we might want to be ready to catch. That's where I'm going with that. Okay, enough about that one. Anaphylactic shock, an allergic reaction. We're going to deal with this in greater detail later. Just take a bee sting, you're allergic to bees. Instead of having a localized reaction at the sting site, you have a systemic reaction. The reaction's all over the body and it causes the vessels to open up. And that's why we use EpiPens, because Epi will do what to that container again? Pull it back together, right? Neurogenic shock. Tubes have what? Smooth muscles. What do these smooth muscles also have? Nerve supply. When that nerve supply is interrupted, those vessels lose, and here's a word of the day, another word of the day, they lose tonicity. I think we said that the other day. They lose tonicity. So if somebody gets stabbed right in the spinal cord, or somebody gets a arrow right in the spinal cord, or they fall from a ladder and it disrupts their spinal cord, everything distal or below that injury is going to lose innervation of the smooth muscles, and therefore the vessels are going to lose their tone and just open up. This is really weird because the patient may be cool and clammy up here, warm and dry down here, because the vessels opened up down here and the warm blood went to the surface of the skin, but up here it's trying to compensate and constrict down. Does that make sense? And so you may see warm and dry on the lower half, pale and diaphoretic on the other half, or cool and clammy.
So when that happens, you just want to be careful in moving them?
You do want to be careful in moving them, and you also want to be careful on, well, you don't have to worry about too much at the EMT level, but you need to be concerned about it at the paramedic level. Because the body is trying to kick out the catecholamines for the sympathetic response, remember? It's kicking out all that adrenaline, all that epinephrine. If that nerve supply ever gets, and nerves do this sometimes, they're just kind of stunned at once. Some of you might have played football and got a stinger in your neck and your fingers were tingly, and then 30 minutes later you're back to normal. So if you ever reestablish innervation, you may go from a blood pressure of 80/60 to 180/160 that quick. Because when you reestablish the nerve supply to those vessels, they kick back up. Not only do they kick back in supercharged with adrenaline or epinephrine. And so the body kind of got fooled there. So paramedics have the ability to give epinephrine through the IV or ADH through the IV or any number of what we call vasopressor agents, which are drugs that pull down on the vasculature. We really do it in septic shock. We give you a lot of epinephrine in septic shock.
Through the IV, you change anything?
Yeah, it makes it immediately available.
Is Levo norepi or epi?
Norepi. And if I was using that in a neurogenic shock and the connection got reestablished, now I've just put them not in a hypotensive crisis, but a hypertensive crisis. So neurogenics, it's a funny one. It's a funny one. No blood loss, but the container opened up. And then septic shock, we talked about that a little bit earlier today. That's an infection in the blood that's causing the vessels to open up. This is a fluid container mismatch, meaning I got a good container, just not enough fluid. This is a fluid container mismatch, meaning I've got enough fluid, just not a good container. See the difference? And then let's go to the top one, which is oh so prevalent. Cardiogenic shock. Cardiogenic shock. And it's simply pump failure. The pump is failing to meet its demands. That can come from so many ways. So many ways. Heart attacks cause pump failure. Dysrhythmias cause pump failure. Age causes pump failure. Drugs can cause pump failure. If you overdose on beta blockers, can your heart pump as hard? So you could have cardiogenic shock induced by non-compliance with medication. The little old lady didn't realize she's already taken that dose twice a day and taking the third one. You want to know what the most common pediatric poisoning is? Beta blocker overdose. Because beta blockers are so prevalent and so widely prescribed, and they're so lax with them, they're not locking them up like a narcotic, that kids are getting into beta blockers and taking a bunch of them, thinking they're candy or whatever kids do, and they go into cardiogenic shock because of beta blocker overdose. And the antidote's really odd. It has to do with insulin and diabetic stuff, trying to get that heart to work harder. The heart has twice the mitochondria that the other muscles have. Therefore, to treat cardiogenic shock due to beta blocker overdose, we try to make the mitochondria work harder. So that's why we give them diabetic-looking medications. And then the final one is obstructed shock. This is when you've put something on top of the railroad tracks and the train can't run now because something is blocking the tracks. Think about clots, pulmonary embolism. Pulmonary embolism is a blood clot that probably started in the lower leg, most likely, has traveled through circulation, went all through the heart like we did it the other day, and it goes off to the lungs, and it goes down that big old pulmonary artery, and then it bifurcates in the left and right pulmonary artery, and that goes into the lung, and it bifurcates down until we get to capillary circulation. So if I've got a clot the size of my thumb that has moved up from my leg, it's probably going to get hung up pretty early in the pulmonary circuit, isn't it?
So you would say that taking a long road trip could cause a pulmonary embolism?
Yeah, sedentary lifestyle, sitting still, could cause a clot to form in your leg, especially if you're prone to clotting.
Feet swollen.
What?
Semi-drivers like
Uh-huh.
feet swollen.
Yep. Airline pilots, because they sit so much, truck drivers sit so much, office workers sit so much, and it's more common in females who are taking hormonal birth control. And if you take hormonal birth control and you smoke and you're female, it's so bad. Here's something you should never forget, and I'm serious about this. Unexplained chest pain and shortness of breath in a female is pulmonary embolism until proven otherwise. So if Chas all of a sudden says, I have chest pain, it happened that quick, I can't catch my breath. What's she have? Pulmonary embolism until proven otherwise. Now, I don't want your medical history, but she's obviously a female of childbearing age. I'm like, are you on hormonal birth control? I'm trying to get some history out immediately. She says, yes, I wear a patch. That's hormonal birth control. Do you happen to smoke? I'm trying to quit. Do you happen to? Yes, I smoke. Okay, we're running with this. We're going to cath lab capable hospitals. And they better get her in a cath lab real quick so they can go in there and retrieve that clot. If they can't retrieve that clot, they need to be administering clot busting agents. Pulmonary embolism is why we have vasectomies. One of the reasons, anyway. A couple who is done conceiving children, she can take hormonal birth control, she can get a tubal hysterectomy, or he can get a vasectomy, and the vasectomy is much less significant, much less side effect. Cardiac tamponade, real quickly, and we'll go into this in trauma a little bit later, but what happens, remember I told you that the heart was sitting in a sac? If that sac fills up with fluid, it starts squeezing down on the heart, so we can't let the heart fill up with blood anymore, and if it doesn't fill up with blood, it can't pump blood. Simple as that, right? And what's cool is the doctor will go and run a needle up through and underneath the sternum and poke a hole in that sac and pull that blood out. And if that's truly what it is, and he or she truly pulls the blood out of the sac, you'll get immediate improvement. That can be done by trauma to the chest, which causes some bleeding in the sac, or it can be caused, and most often is caused by infection, especially in HIV positive patients. They're really prone to infections. That's called pericarditis. You also saw that in COVID. That infection would set up around the heart, and just the pus from the infection can be enough to keep that heart from expanding. You'll know it's cardiac tamponade because when you listen to it with your stethoscope, that lub-dub sound you hear, well, it'll sound like you're doing it underwater. It's muffled because it is literally being transmitted through water.
What's it called when that happens to the lungs and stuff?
You're talking about pulmonary edema or pneumothorax. Yeah, pneumothorax. Either filled with air or filled with blood. And then that's where we're at right here, tension pneumothorax. So Billy, good segue. So when the lungs get air in that pleural space and that air gets trapped and more air gets trapped and more air gets trapped, it starts pushing all the chest contents over to the unaffected side. So let's just say I got a ruptured hole over here in the right side of my chest and the air is getting trapped in there. So every time I take a breath, I trap more air outside the lung against the chest wall. You with me? So if that's allowed to continue over time, all this stuff is going to shift the other direction because that air pressure building up in there. Make sense? So Luke, we have a word for that. That's called mediastinal shift. We'll talk more about that in trauma. What is the mediastinum? Well, we're still doing anatomy, guys. The mediastinum is the center part of your chest that houses the heart and the great vessels. And a tension pneumothorax pushes that heart and great vessels over to one side. And so your vena cava starts getting a kink in it. When it gets a kink in it, blood can't get back to the heart. And if it can't get back to the heart, I mean, you can't pump any blood forward. Is that going to look like low blood pressure shock? I'm out of voice and you're out of time. We'll pick up tomorrow.